So the drugs we need to talk about now are ways to manage not only cholesterol, but we're also going to talk about management of lipids, triglyceride levels too. So the first one to start with is always the easiest one, and that's the statin. That's the HMG-CoA reductase. So we covered a little bit about this yesterday. This is the inhibition of acetyl-CoA to mevalonate. So the statins are going to block that direction. Okay? So the reason that this is an important target is because the acetyl-CoA now has an escape route, so you're not going to build up any unusual intermediates. And this can go to fatty acid synthesis. So one of the potential side effects of statin therapy is weight gain. Now remember that this is clinically not often presented because most people, once they get to this level, are going to be conscious about their diets. And so they won't experience that weight gain. Some will, though. Now, the other thing that I want to mention about statins is that there is this statin intolerance. And the statin intolerance has to do with muscle pain. So when somebody's first prescribed a statin, and they did this to me, they tell you to be very conscious for the first 30 days of the statin therapy, if you've never been on statins before, to identify if you have any unusual muscle pain. And if you have muscle pain, stop the statin immediately and contact your physician. And that's referred to as statin intolerance. Now, why this muscle pain actually occurs, it's still up in the air. But what I've done here is I found this one particular figure to kind of give you just a little bit of some of the thoughts that could be causing this muscle pain. And muscle pain also leads into muscle damage, so myoglobin levels, plasma myoglobin starts going up, so bad. What does high plasma myoglobin do eventually? Problems with the kidneys. So myoglobin, if you have excess myoglobin being filtered by the kidneys, you've got a lot of oxygen there and you've got a lot of potential oxidative damage for the kidneys. So you want to make sure that that's under control. So if somebody's having muscle problems, we have to look at these alternatives that we do for cholesterol therapy. But here's some of the ideas that are being kicked around about why it's causing muscle pain. And it has to do with the fact that you're not only blocking this pathway of cholesterol synthesis, here's where the statin's working, changing the HMG-CoA into mevalonate, blocking this path here, blocking cholesterol, but look what else you're blocking. Geranyl pyrophosphate and farcinyl pyrophosphate. So remember I mentioned those yesterday. Those are also the byproducts of cholesterol synthesis, and these are involved in tethering signaling proteins to the plasma membrane. So here's an example of one, the small effector Rho. Rho has to be tethered to the plasma membrane in order to affect its activity. It's a geranyl group that attaches the signaling protein to the plasma membrane. This activates your transcription factors, and look at what it's affecting. Adhesion, thrombosis, cytokine production, vasodilation. So these signaling molecules have very profound effects, and many of them require the cholesterol synthesis pathway for these tethering molecules. So this type of information here is not testable because this is still theory. It's still in the laboratories trying to dissect out what statin problems are. Exactly. But this is just to kind of primarily place your eyes on the alternative products of cholesterol synthesis that not only are you targeting the molecule that you want to reduce production, but there are some consequences to other molecules that are needed. And this may be what the problem is with developing statin intolerance. Now, how do statins work? Statins are competitive inhibitors. Now, I could end it at that and say they're competitive inhibitors. But this gives me a tremendous opportunity to review something that you got to know up until through the end of February, and then you can completely flush it forevermore. And this is kinetics. So, competitive inhibitor, these types of drugs look like the substrate. So what that simply means is that the substrate here is, in this case, HMG-CoA. And so in order to block the activity of the enzyme, let's design a molecule that looks like HMG-CoA. So this can fit into the active site of the enzyme and prevent the substrate from entering, and therefore you block the activity. So the statin is going to look like that. It's going to look like HMG-CoA, and it's going to have a big group on it, a chemical group. So this portion of the molecule of the statin is going to fit in to the reductase enzyme active site. When that happens, it's going to prevent the true substrate from binding the active site. Now you might ask, well, if this looks like the substrate, why isn't this portion converted into mevalonate? And that's because a chemical group has been added to it that alters the structure enough that it blocks this reaction of acetyl-CoA, HMG-CoA into mevalonate. So it prevents the redox reaction. And that's how generally all competitive inhibitor drugs are designed. Now, what does that look like on a kinetics curve? So if we look at velocity, which is the conversion of HMG-CoA to mevalonate. See how I sneak this stuff in here? Isn't that great? You hate this stuff. I know. But honest to God, I swear you've got to know this for step one. It's on there. So here we're looking at substrate concentration. Substrate, of course, is the HMG-CoA. And if we just take the enzyme itself and we add substrate at increasing concentrations, what we're going to see is faster and faster enzyme activity until we get to a certain point. And that certain point is the Vmax. The maximum velocity that that enzyme can perform will be at the highest concentration of the substrate. So this is our normal kinetic plot. Now what we're going to do with a competitive inhibitor is we are going to mix the competitive inhibitor. So we're going to have an enzyme, we're going to have the substrate, but now we're going to add a concentration of the inhibitor, which is the statin. Okay? What we're going to get is a curve that looks like this. So this is plus statin. So it's the HMG-CoA plus the statin molecule. Now, what we've done is we have not affected the Vmax. Simply because if we add enough HMG-CoA, that is going to prevent the statin from binding to the enzyme because they're competing for the same site. So if you add a lot more of one, the other one doesn't have a chance to get in there. That means ultimately, if we have a lot of substrate, a lot of drug, we will maximize the enzyme activity even in the presence of the inhibitor. But look what we've done for this measurement. Remember, this is 1/2 Vmax. the definition of 1/2 Vmax, we drop a line down here. This is the concentration of substrate that gives you 1/2 the maximal velocity. That's the Km. This is the affinity measurement of the drug for the target. If we shift the curve by adding statin, what we see is a new Km. And this is called Km apparent. The Km for the enzyme for the substrate has not changed. That's an inherent property. But it looks like it's changed simply because we've added a competitor in there, statin. Okay, so this is the definition of how a competitive drug works. Now here's the other graph that you have to know. Remember the Lineweaver-Burke?
That was a laugh of pain.
Yeah, cry.
Oh, that was a crying laugh?
Yeah.
Okay, I know, sorry. So I remember on questions on first aid and USMLE World and all that kind of stuff, that this sort of curve is rarer to know than this. The Lineweaver-Burke is the mathematical interpretation of this. Because this is a hyperbolic curve, we need to transform this into a linear function. And that's what the Lineweaver-Burke is. We're just making this a straight line. On here, the intersection between the y and x axis is the 1 over Vmax. The y-axis itself is 1 over velocity. The x-axis is 1 over substrate concentration, which is, in this case, HMG-CoA. The intersection point of the line for the x-axis is the negative 1 over the Km. So let's say this is without minus the competitor statin. Now, if we add the statin in, on this curve we see that there's no change in the Vmax at high substrate concentrations. So when substrate is out here and reaches infinity, we have no change in Vmax. So this point right here, where the x and y come together, is 1 over the substrate concentration maximum, which is 0, or infinity, on this line. So this is representing the infinity concentration of the substrate, HMG-CoA. So there, both measurements will give us a Vmax, the same one. Now notice that we have, with statins, an increase in the Km, the apparent Km. We're not changing the inherent affinity, we're just shifting it because of the competition. So that means our Km is getting bigger. It's increasing in this direction. Okay? So increasing Km means a bigger number here in the denominator. I know this is kind of pedestrian, but I got to do this with you. So a larger denominator is going to give us a smaller number. Where's our math major? Oh, he's not even paying attention.
I think Emily,
Am I doing this right?
4th grade or 5th grade talked about, is she in 5th grade talked about how this works?
Really? 5th grade? Okay.
Yeah, 5th grade.
Well, I'm going to make it a little more complicated, like
Check my
6th grade.
slides, guys.
So that's going to make this number smaller. So if you plot it, it's going to be closer to 0. Okay? Everybody got this? We draw a line, and this line is plus statins. So the bottom line on this, I know I'm killing you over there. The bottom line is this pattern. When you have the scissors like this on a graph, This defines competitive inhibition. So your step 1 questions are going to describe a situation where you add a drug and you have to determine by the kinetics, is this a competitive or non-competitive inhibitor? So when you see this data, you don't even have to think twice about it. This is how we get to the data, but just know the pattern. That's competitive inhibition. If you see a pattern like this, that's non-competitive. So know those distinctions, know these patterns. You'll get through. It's easy points, and you never, ever, ever have to do it again. Last time I asked my primary care doc what if they could discern a kinetic plot of how the drug works. They just got this dull blank stare on their face. It's like, what? Why would you want me to do that, right? Okay. So that's a competitive inhibitor, and that's how the statin works. Now, the other question is, what does the statin do to LDL receptor expression? And HMG-CoA reductase expression? Because this is an additional factor that you have to consider about these statins and how they work. Okay? So now, a statin, the job of a statin is to decrease cholesterol in the cell. So remember, all cells can make cholesterol, so all cells have HMG-CoA reductase, and all cells have LDL receptor. So this effect's going to be pleiotropic. We typically think the statin affecting the liver, because again, that's the largest concentration of cholesterol made. So now, if you reduce intracellular cholesterol, what is that going to do to the SREBP signaling pathway? So without cholesterol, reduced cholesterol, INSIG dissociates from SCAP, translocation to the Golgi. Now we get our cleavage of SREBP, we construct our transcription factor, goes to the nucleus, and activates. So, sorry.
Yeah, okay.
Almost had you fooled there, right? So decreasing cholesterol is going to increase the SREBP as a transcription factor. That is going to increase LDL receptor. And what's it going to do to HMG-CoA reductase? Increase its expression. So if we increase the LDL receptor on cells, this is a tough question. This goes way beyond 5th grade. If we increase the LDL receptor by this reducing cholesterol, is that good or bad? We're taking it out of the blood. Okay, good, good. So all of you pretty much have the answer, because where I wanted to see if I could stump you was the fact that cells take up cholesterol by LDL. You've got reverse cholesterol transport taking excess out, but what if somebody's HDL levels are low? It sounds to me that if you increase the delivery of cholesterol to cells, that's going to be dangerous. That's counterproductive. So why is your answer correct?
It doesn't cause atherosclerosis when it's in a cell.
Actually, it does.
Never mind.
It depends on if it's in a macrophage and you get increased amounts of LDL cholesterol, you get increased oxidative LDL, so it just kind of exacerbates the problem. What's the organ that has the greatest amount of LDL receptors and its primary function is to protect you against cholesterol? The liver. So this is where it helps. It increases LDL expression, receptor expression everywhere, but by increasing expression in the liver has a trash can. Other cells don't have a way to get rid of cholesterol except for HDL, but the liver has bile synthesis. And so by increasing the amount of LDL receptor in the liver, you clear the LDL receptor faster from the blood, and you expose it to the disposal system at a higher rate. So that's beneficial. What about HMG-CoA reductase expression? That goes up because of the SREBP activity. Wait a minute, that's cholesterol synthesis. Is that a problem? What are we administering? Yeah, what's statin going to do? Inhibit, right? So this activity is going to be blocked anyway. So even though you increase its expression, it doesn't matter because you have a competitive inhibitor in there. So we talk about statins inhibiting cholesterol synthesis, which is absolutely true, but we also have this additional benefit of increasing the clearance mechanism for cholesterol out of the circulation. One other point is the statins themselves. So here's a list of statins because cholesterol synthesis maximizes between midnight and 2 a.m. No clue why. Don't know. Doesn't make any sense to me, but it does. So the traditional method is to tell your patients when you take your statin medication, take the statin in the evening. Take it before going to bed. And that's primarily because the original statins here, lovastatin, simvastatin, Mevacor, and Zocor, look at their half-lives. They're very short-lived drugs before they're metabolized and gotten rid of and excreted. And so with these short half-lives, you need to take this as close to midnight as possible. Now, when we get into some of the newer statins, look at the half-lives. Much, much longer. So that's something to consider if a patient has a hard time complying and remembering with that, before you go to bed. Okay? So that's not testable material, but just to keep in mind that some of the new ones have a little longer half-life. Now, once we have the statin in our body, you have to consider the principle called ADME. What this stands for is absorption, distribution, metabolism, and excretion. So this are the four fundamentals of drug detoxification. So most of the drugs that we're ingesting are being taken care of by the liver. Absorption, of course, is the drug's bioavailability. That's getting into our bodies from the gut and absorption. This is why many of the drugs tend to be very lipophilic, because you don't need transporters for them. They can freely diffuse through the membranes and get into the circulation. Distribution. Sometimes drugs are targeted for organs if they're toxic. That's the nanotechnology that's being developed now, especially for chemotherapy. Metabolism is this. It's the phase 1 and phase 2 liver detoxification system. So the P450 detox system, which includes this particular enzyme, CYP3A4, for cytochrome protein 3A4. This is part of the P450 system. There's a lot of these cytochrome proteins. This one here metabolizes, I believe it's about 90% of all drugs. So how does this system work? There's 2 steps. The whole purpose of the detox system is to make a drug more soluble in the blood. So the drugs tend to be hydrophobic to get across the membrane. They tend to bind to albumin for distribution around the circulation, but then we need to make them soluble for excretion by the kidney. How do you do that with a hydrophobic molecule? The first step is the phase 1. And these are some examples of the reactions. But generally what you need to know is that phase 1, which is the P450 enzymes, are making chemical modifications to the structure of the drug. So for example, we might be doing a hydration reaction. Hydration is adding an OH group. That makes it more polar. Oxidative reductive reactions. These are reactions that can make things more polar, more soluble in the blood. Sometimes that's enough, and you can secrete this into the blood, and then the kidneys can filter this into the urine and get rid of it. Sometimes it's not enough, and we have the phase 2 detoxification. Phase 2 is not technically modifications to the chemical structure, but it's an addition of other chemical groups to the drug. The best example of this is bile salt synthesis. The other example is bilirubin conjugation. So bilirubin is very hydrophobic because it comes from heme. It's not very soluble in the blood. Hence why it tends to cause jaundice and yellowness, because it precipitates, it collects in the skin because it's so hydrophobic. So what do we do to make it more soluble? We add glucuronic acid. So we make a diglucuronide bilirubin conjugate. This is highly polar. Then what we can do is we can put that into the bile because it's soluble. That's an example of a phase 2 enzyme. Okay? Now, why is this important? Is if this particular P450 enzyme detoxifies most of our drugs, this can be competed for. So if you have drug A that needs to be detoxified by this enzyme, and if you have drug B that also needs to be detoxified, if you have a lot of drug A, what's going to happen to the detoxification of drug B? It's going to go down. What's that going to do to the circulating concentration of drug B? It's going to go up. So this is where this is critical to understand, because if you have a patient taking multiple drugs that are all going to compete for the same detoxification, that can effectively increase the concentration of the drug. And if a person's taking multiple doses on a regimen, that concentration of the drug is going to go up and up and up and up. Eventually you'll get to toxic levels. Okay? So this is one of the reasons why no grapefruit when you're taking drugs. Because grapefruit competes for this enzyme, for detoxification. Your patients comply with that? Of course not. I think I've got some grapefruit in my lunch today. But I'm only taking 10 milligrams of a statin. 20 is the normal entry dose. I'm taking 10. I titrated it down so I can eat my grapefruit. 40 is if somebody's got really bad cholesterol levels. 80 is starting to get to the toxicity level. And so some people are on 80, but you have to really watch them for that muscle pain side effects. Okay? Okay, next drug. Ezetimibe. So we talked about cholesterol being taken up from the gut. So here's our dietary cholesterol obtained through dietary. So we talked about fatty acids. We have a transporter. We have a transporter for cholesterol, and that's the NPC1L1. So what's that stand for? Niemann, Pick, C1, Light 1. I did not name this. I would never name it like that. Where this comes from is that the Niemann-Pick C1, NPC1, is involved in an inborn error of metabolism. It's a sphingolipid transporter. So individuals that have a genetic mutation, homozygous mutation, in this gene will be unable to transport sphingolipids. These individuals usually don't make it past 6 or 7 years old, and they typically die of brain problems, neurodegeneration. Why is that? Sphingomyelin is the main component of myelinization. So, what's the relationship of that to this? Nature has found a way to basically duplicate this gene, modify the sequence a little bit, so now it's no longer the NPC1 protein, it's actually NPC1 like the one. That's the name, that's where it came from. And it's involved in transporting cholesterol. So nature has taken advantage of a lipid transporter and modified it so it takes up cholesterol. Okay? So, great therapy, right? If we can block dietary cholesterol uptake, woohoo, we've solved the problem. This works. The drug is called ezetimibe that blocks and binds to NPC1L1, blocks cholesterol uptake, and it actually works. Yes?
So is the NPC1L1 the one involved in Niemann-Pick disease?
No.
Or is it similar to the one involved?
It's similar.
Okay.
So NPC1 itself is involved in the neurodegeneration disease. NPC1L1 has a similar amino acid sequence in the protein, but it has been modified by mutation in nature and selection to be a cholesterol transporter. Statins. Statins are competitive inhibitors of the HMG-CoA reductase. And now we're going to move on to cholestyramine. And cholestyramine is considered a bile acid sequestrant. And what that simply means is that this is going to be binding bile acids in the large intestine, in the small intestine and large intestine. So what does this mean? It's often called a bile acid resin. So those of you that have actually done a little bit of chromatography, you'll remember with chromatography you pour resins into a column, and the purpose of this is to have something bind to it. And this resin is doing the same thing to cholestyramine. What we're going to do is we're going to be binding bile acids. And once we bind these bile acids, then what we're essentially doing is we are inhibiting the uptake mechanism by the receptors in the ileum of bile acids. So instead, we are shunting this material into the stool. Now, what does this do for cholesterol? Well, remember our enterohepatic recirculation, that the bile acids are going to be taken up by the ileum, the terminal ileum. They're going to be sent back to the liver. The liver will take those, reconjugate those, and then put them back into the bile. So that's the normal process. Liver reconjugation, and then back into biliary secretions. So remember, in this path, this process here, we are losing approximately 5% of our bile acids will end up in the stool, and then 95% will be recycled. So the whole purpose of cholestyramine, these bile acid resins, is to bind more of the bile acids so that the ileal uptake is reduced. Now what that's going to do is that is going to push cholesterol into bile acid synthesis. Bless you.
Thank you.
Now, how is that going to happen? Remember the entrance enzyme, the rate-limiting step of bile synthesis. It's the first step. Remember that enzyme?
7-alpha hydroxylase.
Yeah, 7-alpha hydroxylase. So it's a very simple enzyme. All it's going to do is add a hydroxyl group on the number 7 carbon, which is around the corner from the number 3 hydroxyl group. So the chemistry is not very exciting, but the key is that this is the rate-limiting step and the entrance step into bile acid synthesis. Now, if this does not go in this direction, the cholesterol is going to be repackaged, as we saw last week, into VLDL, and that this is going to be put back into the circulation. So the determinant of how cholesterol moves into bile acid synthesis is going to be simply the concentration of cholesterol in the hepatocyte. So as concentration of cholesterol increases, we now surpass the Km of this enzyme. And once we surpass the affinity of this enzyme, now we can push more cholesterol into bile synthesis. So if we have a lot of bile synthesis that is coming around from the ileal uptake mechanism, that is going to have a high concentration of bile acids in the hepatocyte, which will actually inhibit the 7-alpha hydroxylase. Okay? So the principle is if somebody is suffering from hypercholesterolemia, you want to get their cholesterol down, let's sequester the bile in the intestine with this bile acid resin, and then we will reduce the amount of bile that returns to the liver, and so now the concentration of cholesterol is much higher than the return concentration of bile acid, and that is going to push this reaction into bile synthesis. So what we end up having, essentially, is a net flux of cholesterol into bile acids, and likewise, when we sequester the bile acid in the intestine, we are going to have an increased net flux of bile acids into the stool. So this is a way to start pushing some of that cholesterol through the biosynthetic pathway and decreasing the concentration of cholesterol that's in the body. So the overall effect of this is to decrease LDL-C. Now, if you have statins available to you, which is going to block HMG-CoA reductase, block endogenous synthesis of cholesterol, that's going to increase the amount of LDL receptors on the hepatocyte surface so that you can clear more LDL-C. Why would you ever think of using a drug like this? The statins are so effective.
What if they can't take statins?
Yeah, if they can't take statins. So if they're intolerant to statins, what's the first symptom that they would indicate if they're intolerant to statins?
Myalgia.
Yeah, muscle pain, muscle weakness. That usually occurs right away within the first 30 days. Okay, so that's a very simple principle. Now we have the next one. This has got to be the worst doc cam I've ever seen. You should bring mine. So I think you've got all pictures on your iPads and computers. So this is niacin, nicotinic acid, vitamin B3. We'll talk more about the vitamins next week. But vitamin B3, niacin, also called more popularly nicotinic acid, is going to bind to a specific receptor. And this specific receptor is on multiple cell types. The one here primarily it's on is the adipocyte. So this is a cell type in adipose tissue. And this is going to counter an effect that we're going to see today. When we look at, we're going to start shifting into the fasting state. What this receptor does, the nicotinic acid receptor, it's a 7-transmembrane receptor. And this is going to bind, G-alpha I. So this is going to activate the G-alpha I heterotrimeric G protein. G-alpha S, the stimulating G protein, is what we're going to see today moving into the fasting state in adipose. And the purpose of G-alpha S is to stimulate fatty acid release. So this is going to be our fasting signal for fat cells to let go of the fat that it's previously stored. The G-alpha I is going to inhibit this process by inhibiting adenylyl cyclase. That process will ultimately decrease, this inhibition will decrease protein kinase A activation, and it's going to decrease free fatty acid release from adipocytes. So the overall effect of niacin on this is to decrease the efflux of fatty acids from adipose tissue. Now what that's going to do is that's going to prevent fatty acids from getting to the liver, and it's going to reduce the amount of triglyceride synthesis because we have less substrate available. If we have less triglyceride substrate, we have a reduced amount of VLDL formation, and therefore a reduced amount of circulating lipids. So as long as we keep those lipids inside the fat cells, we're good to go. The other thing that nicotinic acid is going to do is it's going to inhibit one of the enzymes that synthesizes triglycerides in the liver from these free fatty acids. So the overall effect of using niacin is to reduce fatty acids. So this is a good treatment for hyperlipidemia, primarily hypertriglyceridemia, reducing overall fatty acids. Now, what's the problem with niacin treatment?
Can't lose weight.
Weight loss is difficult because you're blocking the normal efflux of fat out of fat tissue. What's the other physiologically uncomfortable effect? Flushing. Yeah. So this type of problem, hypertriglyceridemia, is usually, males tend to have this problem worse. So what the niacin is going to do is it's going to cause this flushing effect. And the flushing effect is largely the effect of niacin on endothelial cells. What the niacin is going to do is it's going to increase the synthesis of prostaglandins. And we're going to talk more about prostaglandins next week. But prostaglandins are small lipid effectors. They're primarily seen in inflammatory responses, but they also can control basal tone. And so this increase in prostaglandin is going to decrease vascular tone, and it's going to increase blood flow into the periphery. And there's your flushing effect. Okay, so that's the niacin effect. So this one here is primarily for hypertriglyceridemia. Now the next one are the fibrates. Fenofibrate, gemfibrozole, chlorfibrate, and benzofibrate. So all of these fibrates are going to be working by modifying a transcription factor. So the fibrates are going to bind to and activate a transcription factor called PPAR alpha. And PPAR stands for peroxisome proliferator activated receptor, more commonly addressed as PPAR. Now these are considered master transcription factors for metabolism. There's a whole series of them, PPAR alpha through gamma. PPAR gamma is the one that we are going to talk about when we're targeting the anti-diabetic drugs, the glitazones. And we're going to talk more about this pharmacology in endocrine And Dr. Leanna Cunningham is going to give she gives a really good description of the mechanism and how the glitazones work on PPAR gamma. Again, this is a transcription factor. This one here we're talking about with fibrates is PPAR alpha. What PPAR alpha does is when it binds its ligand, in this case we're binding the drug ligand, the fibrate, it's going to translocate to the nucleus and it's going to bind with RXR, which is the retinoic acid X receptor. So you've probably seen RXR before. RXR is like LXR. These are co-transcription factors that will bind to other transcription factors and form these dimeric structures that now can sit down on promoter elements in the genome, in the nucleus. What PPAR alpha is about is, think about increasing the burn. So PPAR alpha is going to activate a whole series of genes to increase oxidative reactions, primarily in liver, but also in skeletal muscle. The big one that it's going to do is this one right here. It's going to increase beta oxidation, which is fatty acid oxidation. So by increasing the burn rate, increasing the oxidation of fatty acids, we're going to generate more ATP, but the most important part here is that we are going to be able to start reducing our hyperlipidemia. Simply because we are increasing the number of enzymes that are involved in this reaction of oxidation. So the more oxidation we have, the reduced internal amount of fatty acids that we have. Okay? Don't worry about some of these side effects. Don't recall any questions that you have to worry about up to this point, up to step 1, about any of these extra side effects. We'll talk about serum homocysteine next week when we talk about vitamins, vitamin B9 and B12. But the primary information here is the mechanism of the fibrate working through the PPAR alpha, and the PPAR alpha is going to increase the genes for fatty acid oxidation. Yes?
Is RXR a transcription factor, or
Yes.
it's already there?
RXR is a transcription factor that's located in the nucleus. And so the delivery of PPAR alpha, once it binds to its ligand into the nucleus, now they combine and boom, they can sit down on the promoter element. And RXR is a rather pleiotropic transcription factor, so it is able to bind to a lot of other transcription factors and mediate this transcriptional activation. Okay, next one, our final one. This is a new one. Magic. That's a little better. PCSK9. So has anybody heard about PCSK9? Okay, some of you have. So this is the latest discovery in controlling LDL cholesterol. The normal function of PCSK9, this protein is involved in controlling the half-life of the LDL receptor. So this is a relatively new discovery over the past maybe 5 or 6 years, that this particular protein, PCSK9, is located bound to the LDL receptor. So if this blue here is the LDL receptor, this little cluster of protein here is PCSK9. And what this protein does is, upon internalization of the LDL receptor, this receptor goes into endosomes, and then the bound PCSK9 is going to direct the LDL receptor to degradation. So this is degradation of the LDL receptor. So under normal conditions, if you downregulate the LDL receptor, what is going to happen to plasma LDL levels? They're going to go up, yeah. Now, why would we normally want to downregulate the LDL receptor? What's a logical, normal reason for downregulating this receptor? What upregulates the receptor expression?
Decreased cholesterol.
Decreased cholesterol. So when your cholesterol goes down, your SREBP pathway is activated, so you increase LDL receptor expression to take in more LDL from the outside. So why would you want to downregulate the LDL receptor after you've gone through all of that new biosynthetic activity to put it on the surface?
Your cholesterol increases.
Yeah. Your cholesterol is increasing. So as cholesterol increases in the cell, you are going to shut down the SREBP pathway simply because you want to shut down cholesterol uptake and synthesis. So if the LDL receptor stayed on the cell surface forever, you would constantly be taking in cholesterol even if you had sufficient cholesterol inside the cell. So this is the normal mechanism to turn over the receptor to essentially what's called downregulate it. Reduce the amount on the cell surface. Okay? Now, so this turns into a really nice target, right? So if we make antibodies to PCSK9, these antibodies will recognize the protein and dissociate it from the LDL receptor. The consequence of this is that the LDL receptor now is going to spend more time on the cell surface undergoing that recycling pattern, so it can take up more LDL-C and then recycle back to the surface to take up even more LDL-C. So now remember, these antibodies are generated, these are monoclonal antibodies. They're typically generated in mice. Monoclonal antibodies generated in mice. So that means that these antibodies, every antibody in this solution has two antigen recognition sites. These are typically IgG molecules. And these antigen recognition sites are identical on both of the divalent structure of the antibody and also every antibody in the solution. So that's the monoclonal. Every antibody is to the protein. So that increases the effectiveness. Now, why are we injecting a mouse protein into human? What will that do to the immune system? Will that activate the immune system? A foreign protein, a mouse protein. Oh yeah. So this is mouse. We first make it. So how do we avoid the immune system activation? What's the proper term for that? What are we going to do to the antibody?
Throw some human protein on it.
Yeah, we are going to humanize it. Humanize simply means that we are going to take the FC region, the constant region, and we are going to substitute the mouse sequence for human sequence. And that's humanizing an antibody. And by doing this, you significantly reduce the immune response. Now, does that eliminate the immune response? Not so much. Some people are intolerant to this because there's still some mouse sequence on there. But by replacing the majority of the FC region by human sequence, you reduce the immunoreactivity.